Welcome back to the RX class. I'm your host, Dr. Guang Chen. I'd like to thank the ongoing support from patients and colleagues, which makes this all more rewarding. Today's topic comes from something that my children read recently. As part of a birthday present, I recently purchased a couple of medical books by Adam Kay. Well, he was a junior doctor and is now a very popular author. One of the books I purchased was called Kay's Anatomy. And within there, while there's lots and lots of good sections, and I'll put a link below, one of the sections was about death. And as a doctor, unfortunately, death is part of our, perhaps not day-to-day practice, but an irregular occurrence amongst our patients. And I really did take some time to think back my long medical history. And these are the two stories that I told my kids, and I hope I can share with you. But before I begin, please note that throughout the podcast episode, the information presented is general in nature and use your own risk. Complex concepts may be oversimplified for entertainment purposes. Symptoms, medical conditions, as well as diagnosis and treatment of these conditions may be mentioned. The information presented does not constitute a practice of medicine nor replace medical advice from a licensed medical professional. Do not rely on the information to make decisions about your or someone else's health. Please seek help from a certified health practitioner if you have concerns or symptoms. I begin with the first story, which is my first encounter with death. And I think maybe at the time I was 2 or 3 years old. Some of these memories are a little bit sketchy, and it's hard to know whether these were real or somehow I've made these up. When I was, I guess, presumably a toddler, my maternal grandfather developed the condition known as motor neuron disease, with the specific form known as LLS, or amyotrophic lateral sclerosis. Just to tell you a bit more about my maternal grandfather, he was in his early 60s. He was a very fit man, and he had actually had a very good basic understanding of medicine, as he had trained as a pharmacist. I remember at the time, he developed weakness and atrophy, or the shrinkage of muscles, first in his arm. And I think I remember helping him doing his physiotherapy exercises at the time. And I also remember just before he got sick, he would take me to get ice cream. At the time when I was living in Shanghai, ice cream options were limited. And the most famous ice cream was a brick-like ice cream, a vanilla-flavored ice cream. And I remember fondly the memory of him taking me to get the vanilla brick ice cream. And as the time progressed, I remember he began to have issues with swallowing. And ultimately, I don't remember the exact situation of his passing, but I do remember perhaps attending the funeral and everyone was dressed in black, and it was one of the few times that I saw so many family members crying. And fast forward that to perhaps about 15 to 20 years ago, which is my next story about death. It was the first night shift when I was a junior doctor, when I was an intern at Concord Hospital, which is a hospital in metropolitan Sydney. At the time, as junior doctors, we would work a job from, say, 9 to 5. At the time, I think I was doing a surgical term, working with the colorectal surgical team. And then all of us would share the after hours, which would approximately go from 5 o'clock to 10 o'clock. And then there'll be somebody who would cover the overnight shift from 10 o'clock to 8 or 9 o'clock the following day. It was my first week, actually my first day on after hours shift. I really didn't know what to expect. Normally, some of the senior registrars would give you some help, give you some hints about what to expect, and typically it might be renewal of medication charts, adjustment of medication doses, small adjustments. Large adjustments wouldn't come to after hours, and possibly the certification of death. And we got some more tutorials about what to do in that situation, but I'd never thought that it would come on my first hour's shift. And I remember very vividly that evening I was just finishing up some other paperwork, and I was just sitting down to have a bit of a breather, and the paging system rang, and I called the ward, and the nurse that was in charge that evening called to say, "Oh, look, we've got Mr. AB who's passed away in bed 10. Would you mind coming to certify his death?" And as I'm speaking about it, I recall the moment very well, and I totally went cold, and my whole body kind of froze because I didn't really know what to do. And I quietly said to the nurse, "Okay, well, thank you for letting me know. I'll be there soon." And before I'd set off from the doctor's office, I reviewed my notes about the certification of death, and I went through it in steps of identifying brain death, identifying cardiopulmonary arrest, make sure I checked the pulses, check the breathing, check responses to voice and pain, make sure I listen to the heart sounds, have a listen to the lungs. And all of these things kind of raced through my mind over and over again about what I needed to do to certify the death. When I finally arrived at the ward, again, I didn't really know what to do. It was my first time. The nurse saw me and she waved at me and said, look, and she directed me towards the bed 10. I initially stood outside for a little bit because I saw there was a large number of family members. So I thought I'd decide to read the medical file. It was a very long medical file, and which only had one volume of his most current admission at the time. He was a Greek man in his late 80s, and from what I could read, he had been in and out of hospital many, many times, especially in the last 12, 24 months leading up to the time that he was admitted. At that point, I could see that he had a lot of medical problems, the main one being heart failure or cardiac failure, which stemmed from a heart attack that he had many, many years prior. And over the years, his heart essentially weakened, and he was in a hospital because he kept on retaining fluid, and he couldn't breathe, and he had trouble walking. And every time he'd come to hospital, he'd be put on the special drips inotropic medication, which would help alleviate some of that stress. And he would go home, and he would come back again and go home. But perhaps at the time, I didn't realize the significance until much later. He did have a document known as an advanced care directive. It was a very different document to what is usually written today, but it was very clear. And it stated that what he wanted, he didn't want a CPR, cardiopulmonary resuscitation, if his heart was to stop. He didn't want to have any external machines to keep him alive, such as a breathing tube. He didn't want to be externally fed. And I thought, wow, that's such a powerful document. After I read this again, I took some time to think about it. And again, I didn't really appreciate the gravity of this document until actually many, many years later in my medical career. And after I read the documents, I was kind of ready. And I approached the room. I gave the door a gentle knock. One of the family members, I think perhaps one of the grandsons, opened the door. And I entered the door and I gently introduced myself. I said, look, my name is Guang. I'm the after-hours doctor looking after the wards tonight. The nurses have asked me to come and certify the death. And the grandson looked at me and directed me towards the bed. And as I walked in towards the bed, it seemed his whole family were there. I saw a very elderly woman. I presume it was his wife. Again, he was surrounded by many of his older children, grandchildren, and I think there were several great-grandchildren. Everyone looked so peaceful. And the patient himself was also peaceful. I asked if I could certify the death, and they said, please go ahead. When I approached the patient and I did the examination, the memory still remains. I could feel the warmth in his hands, yet there were no signs of life. He had stopped breathing. There was no pulse. There was no reaction to my voice or to pain. He had passed away. What seemed like an eternity was only several minutes. And after I completed my job, after I'd finished my examination, I excused myself from the room. I remember writing down what I had found, and I'd written the time of death. And then I was asked to fill out paperwork, which included the certificate and cremation certificate. This very memory remains with me, and every time I talk about it, I still I still slow down and almost relive it. Since then, I've been part of the care of many other patients who have subsequently passed away, and it's not any easier today than it was when I was a junior doctor. But perhaps what I have learnt is discussing the potential of illness and death early with patients and family. And what I've found that many patients really appreciate this. And it's taken me a long time to become comfortable with doing it. And as a junior doctor, I really did feel quite awkward because at the time I didn't know what to say and I didn't know what to expect. But over time, I guess I've learned the right words and learned that many families really want to discuss it, but even from their point of view, they're afraid of what they might hear. And so so I've learned that It's often a lot easier if I start the conversation rather than waiting for them. Death is an unusual process, and almost all illness leads to death in some way or form, some quicker and some slower. And they ultimately end in the organs stopping working, or they fail. And that might be one organ, or there may be multiple organs happening at the same time. And one of the most important things I tell patients is, and I try to reassure them, is that our goal is not to give up. Our goal is to always aim for quality of life, and we get help from many other teams and doctors along the way. And one particular team which is very good at this is palliative care. Unfortunately, many patients misinterpret what palliative care really means. Palliative care is often thought to be end of life, about keeping people comfortable in the last moments of their life. And that is very true. They are very good at doing that. They're very good at maintaining comfort and pain control at the very last moments of life. However, the palliative care team often have a role much earlier. And again, this is sometimes difficult for patients to accept. Palliative care can be helpful in setting up the home, helping with extra services, extra therapies to maintain their strength so they can stay at home longer. Palliative care also provides services such as respite care, so that patients may stay in. Palliative care also may provide respite care, and patients can be looked after while their family have a break. So it's very, very important to do a marvelous job of helping patients when they're well and also when they're unwell. The other things I normally tell patients, the other thing are more about decision making. So while there are lots of legal documents such as wills about the division of assets or how financial decisions are made, such as the enduring power of attorney, from a medical point of view, I normally highlight two important documents. One is enduring guardianship, and second is the Advanced Care Directive. The enduring guardianship is a legal document where the patient or actually anyone can elect somebody else to be responsible in the event that they are no longer able to make decisions. And so this document is normally made when the patient has capacity, and it often is made in front of a legal professional. However, this can vary, obviously, from country to country and jurisdiction to jurisdiction. In Australia, the enduring guardianship comes into effect once the patient loses the capacity to make their own decisions, and the guardianship role predominantly determines about where the patient may live and also about their medical decisions. And so, for example, the enduring guardian can make a decision about keeping the patient at home. They can also make a decision about whether the patient needs additional care, such as in an aged care facility. They can also make decisions about the ongoing medical care of the patient regarding the potential of further invasive treatments, such as surgery, invasive tests, as well as potentially the withdrawal of treatment as well. Now, one document that I spoke about that is very helpful is the Advanced Care Directive. And so it's a document that one makes when they have capacity about their views or values about their health and what they want and what they don't want. Look, there are lots of different forms. However, the New South Wales Health, which is available here in where I work, is a very good document. And I'll link that in the show notes. And it does make it relatively easy to understand. And I'll just highlight some features from that document. And so within the first part of the document, it asks about your personal values about dying. Again, you can fill in as much or as little as you like of this particular form. And some of the questions include, if I no longer recognize my family and loved ones, I would find life bearable, unbearable, unsure. If I cannot feed, wash, or dress myself, I would find life bearable, unbearable, unsure. If I no longer can eat or drink and need to have food given to me through a tube in my stomach, I would find life bearable, unbearable, unsure. And several others. And this gives us an idea about what you may or might want. And in terms of these forms, often I'd recommend while you fill that out, as you fill the forms out, to discuss the different, or use it as a talking point for your family and friends, as well as perhaps the doctor who might be looking after your general practitioner or your specialist. The second section is about the personal values about dying. So this is a question about whether you would like to stay at home or whether you'd like to go to hospital. or another location. It's also whether you want maybe perhaps not just perhaps another person to decide on your behalf. There are some additional complexities if one chooses to die at home. And again, that often relates to the certification of death. In a hospital, we've got doctors almost 24 hours a day, and the certification can be done relatively quickly. However, when you're at home, one may need to wait for a general practitioner or a family doctor to attend the home. That may be potentially many, many hours or even the following day that this can happen. And the third section in the New South Wales Advanced Care Directive Form, it's about directions about medical care. Here, you can decide about resuscitation or cardiopulmonary resuscitation, which is doing chest compressions or using the defibrillator to restart your heart, as well as additional other invasive treatments such as using a breathing machine or having dialysis. The last section, which I think is also very important, is about your choices about organ donation, whether that be for someone else to use or for medical research. And I think this particular section is worthwhile talking to your family and friends about. Death is something that we're all uncomfortable to talk about, but I think it's an important topic to discuss with your family and friends, and also with your treating doctors. Some of the decisions are confronting and sometimes very awkward at the time that you're faced with. But I think if you make the decisions early, it will make the overall process less stressful for yourself and your family. And remember, these decisions can be changed almost at any time. I don't feel pressured. Thank you again for listening to the podcast, and I'll see you next time.